This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
Alright, this is going to be wide complex tachycardias, and this is going to be AHA 2010. Topics we're going to discuss here is going to be pathophysiology. I'm going to do a quick pharmacology review. I'm going to talk about treatment algorithm, and then we're going to do a scenario. This is Vtach, and it is monophasic Vtach. The reason we call it monophasic is because it is coming from one direction. And let me point that out right there. If it had multiple locations, or many, more than 4, we would call it polymorphic. Which we'll see here in just a minute. But this is monophasic Vtach, and it is all going in one direction. So characteristically, it should be wide and aberrant and greater than 150 beats per minute. There's one right there, 300, 150, greater than 150 beats per minute. QRS width is greater than 0.12. This is polymorphic Vtach, and the reason that it's polymorphic is it's coming from multiple locations. Now, the polymorphic Vtach that we're looking at here, the reason that it looks like that is because we look at one pole or one viewpoint, and that viewpoint, as it gets closer to it, the amplitude increases. As it goes away from it, the amplitude decreases. The closer that the amplitude or the point of origin gets into the direction of the negative electrode, you'll get negative deflection. When it gets closer to the positive electrode, positive deflection. And we get this wave-like fashion. So both of these, this is Vtach with a pulse algorithm, so both of these can generate a pulse. However, looking at torsades, I would say that if it is generating a pulse, that it will not last for very long. This is a wide complex tachycardia, and without understanding axis or looking at a 12 lead, this may be of unknown origin. You might not discern this as Vtach, but it is wide and aberrant. It is also greater than 150 beats per minute. So, very simply, if it's a wide complex tachycardia and it's greater than 150 beats per minute, and you think that the cardiac symptoms are being caused by this, you should probably correct it. Pharmacology review are going to be these medications right here: amiodarone, lidocaine, magnesium sulfate, and procainamide as antidysrhythmics. First one on our list is going to be a primary care drug, and it's cortisone. And this thing pretty much, alpha, beta, potassium, and calcium, blocks everything that we have to generate an actual beat. So blocks some of the sympathetic nervous system. It has a calcium channel blocker in it, and it also has a potassium channel blocker in it. Amiodarone has the Von Williams classification of a class 3, which is a potassium channel blocker. Our primary indications for this are going to be Vtach, VFib, atrial fibrillation if it's wide, and SVT again if it's wide. The pharmacokinetics of this thing, this stuff sticks around like luggage. 26 to 107 days depending on how your liver is doing. And the adult dose is going to be 150 milligrams over 10 minutes. And we're going to do this that can be eliminated. We're going to do this times 3 for a total of 450 milligrams. However, I want you to be aware that 450 milligrams will go in over 30 minutes. Absolute contraindications: if there's any kind of high degree heart blocks, if there's a physical block present, you have no need to put on board a chemical block. And drug interactions, other antidysrhythmics, beta blockers and calcium channel blockers will potentiate the effect of this. Amiodarone has proarrhythmic contraindications between it and procainamide, which means you'll pretty much create this on the monitor. Lidocaine also is a primary care. It's an alternate that we use in case the person is allergic to amiodarone. Extends phase 4 repolarization, and this is a sodium channel blocker. Primary indication on this is going to be ventricular arrhythmias. Adult dose is going to be 0.5 to 1 milligram per kilogram. Maximum of 3 milligrams per kilogram. Now we're going to push this kind of slow over at least a couple, 2 or 3 minutes, whenever we bolus. This is one of the medications, if we convert the patient, that we would have to hang a maintenance strip. And the maintenance strip dosing is 1 to 4 milligrams per minute. Procainamide is another one that has the same dosing for the maintenance. So this is a maintenance dose. Absolute contraindications obviously is an allergy or any kind of high degree heart block. Again, if you have a high degree heart block, 2nd or 3rd degree, and you have on board a physical block, putting on board a chemical block would not be healthy. Magnesium sulfate, primary care. The number one cause of torsades is low magnesium levels. So if we see somebody that has polymorphic Vtach, wave-like fashion, then we're going to be considering magnesium sulfate as an antidysrhythmic. And the adult dose here is 1 to 2 grams over 1 to 2 minutes. Absolute contraindication is going to be renal disease. Procainamide, or Pronestal, also a primary care drug. This actually holds a von Williams classification of a class 1. It has the ability to decrease conduction velocity and has some anticholinergic properties, which means it obliterates parasympathetic tone, anticholinergic properties. The primary indication of this is going to be this, and if you're looking at a 12 lead and you look at the axis, you should never have to give the diagnosis of this. This is wide complex tachycardia of unknown origin. If you're using axis and the 6 different ways of actually looking at a tachycardic rhythm or Vtach, then you should be able to identify Vtach. Obviously, another primary indication is going to be Vtach, VFib. It's also used as an alternate. Again, this has a proarrhythmic contraindication with amiodarone. You cannot use them in conjunction with one another. And then atrial fibrillation with rapid ventricular response. This is a good medication for. Adult dose is going to be 20 to 30 milligrams per minute, and this is going to be in the form of a drip. The best way to put procainamide on board is to mix 1 gram or 1,000 milligrams. Into a 50 ml ad bag. That gives you 20 milligrams per milliliter. And the easiest way to deliver that is going to be 60 drops per minute. Now 60 drops using a 60 drop set will deliver you 1 milliliter and also deliver you 20 milligrams of the drug. If you convert the patient, then you will have to hang a maintenance strip of this. The maintenance strip of procainamide is 1 to 4 milligrams per minute. As far as dosing goes, you want to mix it to 4 milligrams per milliliter, 2 grams into a 500 bag, the 2 grams converts to 2,000 milligrams. 20 divided by 5 is 4 milligrams per milliliter. And then 1 to 4 milligrams per minute. Absolute contraindications on this are going to be high degree heart blocks. Again, if they have any kind of heart block present, you do not want to put on board a chemical block, and any kind of bleeding disorders. The 4 things that any one of these 4, and you can stop the percanamide drip. And I'll go over these really quick. A lot of people forget about these. Let me clean up the slide set here just a little bit. So the 4 things that must be present. Ectopy stops. Hypotension develops. QRS widens greater than 50%, or 17 milligrams per kilogram have been given. One of those 4 things, any of those 4 occur, and you need to stop the percanamide drip or the percanamide bolus. If the ectopy stops, the patient becomes hypotensive, the QRS widens greater than 50%, and 17 milligrams per kilogram have been given. As far as treatment, this is the American Heart Association's 2010 treatment algorithm. And a good thing to start with would be to identify the underlying cause, put the patient on some oxygen if they're hypoxemic, cardiac monitor, wire them for sound, get a 12 lead. If they are symptomatic and unstable, and that's what this block here is, the number 1 thing would be hypotension. So that would be a blood pressure, systolic blood pressure less than 90 millimeters of mercury. Acute altered mental status, they have an altered LOC and you think that it's from this rhythm. Signs of shock, they look like they are in some form of hypovolemic shock. Ischemic chest discomfort, chest pain. Acute heart failure, this would be pulmonary edema, would be a really quick acute sign. If any of these are present, or a multitude of these are present, again, hypotension being our number 1 method of determining instability, then we need to synchronize cardiovert our patient. Consider sedation. If there's not enough time for that, better bad dreams than no dreams at all. We're going to shock this in a pattern of, if we're using a physical control model, of 100, 200, 300, and then 360. Now, some things I need to tell you about here. The sync button needs to be reloaded every time. Whenever you deliver the shock or the cardioversion, be sure to press and hold the delivery button. The reason being is because whenever you have the sync button on, it will wait until the next R wave falls. This is going to be the section we're looking at right here, though. Do they have a wide QRS? And these are wide complex tachycardias. The answer would be yes. And this is what they would like you to do. So obviously get a 12 lead. Consider adenosine only if it's regular and monomorphic. So if it's coming from one direction and looks like shark teeth, we may try a bout of adenosine. Consider antiarrhythmic infusion, and these are our antiarrhythmic choices over here. And then consider expert consultation. So if we have the cardiologist on speed dial, that would be the time. Percanamide, this is the bolus. We talked about it. Amiodarone, 150 milligrams over 10 minutes. Repeat as needed. And then the maintenance infusion for this is going to be 1 milligram per minute over the first 6 hours. And then sotalol is pretty much an ER drug. Hasn't made it quite to the EMS yet in the streets. So 100 milligrams, 1.5 milligrams per kilogram over 5 minutes. Avoid if you have a prolonged QT, because this can actually give you a prolonged QT. Sotalol is a type of beta blocker. And that's pretty much where we are. So we're going to stabilize things. We're going to perform an ALS bridge. And whenever we perform our ALS bridge, putting the patient on oxygen, getting a good history, sample OPQRST history, dropping in an IV for a drug route, and then giving them 150 milligrams over 10 minutes. Amiodarone would be at the top of our list as far as antiarrhythmics go. Scenario 1. You have a 45-year-old male with onset of fluttering in his chest. Patient is found ambulatory and walks up to your ambulance. He appears pale and diaphoretic. Vital signs: blood pressure 120 over 70, heart rate 150 beats per minute, respirations 28, EKG shows this.
Perform a primary assessment, airway, breathing and circulation, vital signs, and monitor. Obtain a sample OPQRST history. Start an IV or IO. Administer 150 milligrams of amiodarone over 10 minutes. Transport to an appropriate facility.
Your second scenario is going to be a 60-year-old male with onset of chest pain and syncope. He appears pale and cool and diaphoretic, with a decreased level of consciousness. Vital signs are blood pressure 70 over 40, heart rate 150 beats per minute, respirations 32, and the EKG shows this.
Perform a primary assessment, airway, breathing and circulation, vital signs, and monitor. Obtain a sample OPQRST history. Consider sedation. Cardiovert 100, 200, 300, and then 360. Transport to an appropriate facility.